And so I'm going to wait for just a few more minutes before we introduce our speakers. I think that we'll have some folks continue to join us. I'm just watching the live stream as it ends. Maybe, Damien, we could launch our poll. So we'll keep this open for a bit, but for those of you who are with us, we have a poll here, which Damien will pull up, and this is just to get the conversation started. So in responding to the COVID-19 crisis, it's most important to focus funding and resources to address the immediate crisis and short-term needs, understand the plan for long-term consequences or other. So if you have a response other than that, please note it in chat. Yeah, let's hear the results, Damien.
All right, so if you're addressing the imminent crisis and short-term needs, is about 31% of the folks in the room. And at 69% is understand and plan for long-term consequences.
All right, great. And I don't see
there's no votes for other.
Yep, I don't see anything here in chat. So there's some information to get us started. And with that, I will introduce our wonderful guest speakers here. So we have with us today Sophie Harman, who is Professor of International Politics at the Queen Mary University of London. We also have with us Ahmed Arale, Secretariat Director of the core group Polio-GHSA project in Kenya and Somalia. So with that, we'll start again with some words from them and invite you to chat in your comments as you're listening. So Sophie, please, I'll turn it over to you, to this small and mighty group for a wonderful conversation.
Great, thanks so much, Elise, and thanks everyone for joining the group. But also no thanks, because you ruined my start, because the poll you were meant to respond addressed the immediate crisis, because that's normally what people do. So we know with pandemic health emergencies, the tendency of responders is to say, focus on the crisis, put out the fire, do whatever you can to stop this from spreading. Now, as you wise people, as gender experts know, that's actually had some really serious consequences for women, as because focusing just on the crisis alone tends to exclude women and gender and women's issues. Now, when I've raised this in the past, most particularly in the Ebola response in 2014-16, lots of people looked at me and said, who cares about women? Why are we doing this? We have Ebola to respond to. It's a crisis. But the problem is, we know that whilst viruses don't discriminate, we all are susceptible to COVID-19. Viruses do exist in societies that do. And the burdens of pandemics and health emergencies are really particular to women. So we need to have an approach that takes in both the immediate impacts on women and the long-term consequences for women in the work that we do. So a quick recap of why we need to have a gender approach at the start and why this is particularly relevant to humanitarian settings. And then I'm going to offer some suggestions about what we could perhaps think about doing going forward with the COVID response. So 5 quick reasons of why we really need to pay attention to some of the gender issues and women involved in COVID-19. So firstly, we know that women are particularly vulnerable as frontline care workers in the COVID-19 response. Around the world, the majority of care workers are women, and that's in paid care work. We'll come to unpaid care work in a moment. So that makes them particularly vulnerable. We also have to understand the nature of the care work that they do and target our interventions appropriately. So with any type of health emergency, you always have to protect your frontline healthcare workers and care workers. And this is where we think about women. The second issue as well is that women are also on the front line in their own homes in terms of the domestic care work and burdens that they take. So this can be in somewhere, where I am in London, in a high income country, where women are taking on the burden of homeschooling and domestic work under certain quarantine and lockdown measures. But this also applies to extreme settings as well. So who is doing the behaviour change communication in their homes? Who is providing key services in their homes, even if they are in informal settlements? It's women. So women have an additional burden that is exacerbated by health emergencies. So this is what health and pandemics do. They create problems and they exacerbate existing inequalities. We also know that historically, women's health needs tend to be sidelined or overlooked in the wider, sorry, I was looking at the chat, I've introduced myself, that's fine. We know that women's health issues tend to be overlooked or sidelined because of the emergency. And most notably, if we look at Ebola in 2014-16, was the data around women dying more from pregnancy-related complications than Ebola because they weren't protected, again, because they weren't seen as a primary issue. Now that's one extreme example, but we can also see disruptions in women's access to other fundamental forms of healthcare, most notably contraception, for example, as supply chains become disrupted to prioritise the response to COVID-19. The very extreme element of this, some political leaders use the pandemic as an excuse to curtail access to contraception and women's access to sexual and reproductive health rights. Now, this is universal, but this is particularly a prescient issue within those women who are facing intersecting inequalities and extreme forms of poverty, who have a limited access in the first place. So you can see these issues becoming hugely compounded by COVID-19. The fourth issue is, of course, violence against women, particularly domestic abuse. So when we think about measures to respond to COVID-19, whether that's lockdown or particular types of quarantine, we have to look at who's vulnerable within those quarantine systems. So it doesn't take anyone who knows anything about violence against women a great leap to understand if you shut women in their homes, those homes aren't safe for everyone. And of course, men are also survivors of and victims of domestic abuse, but we know that this predominantly affects women. Again, this is exacerbated by those who are the most vulnerable in society. Finally, you can see long-term women having both a serious economic and political hit from the virus. So economically, this is about economic autonomy, ability to sustain their livelihoods in the very basic element, or their careers for those women who are living in higher income countries as well. So when we think about the consequences of COVID-19 in the long term and the economic burdens it has on states, that is going to be hit by women, both with their economic autonomy and the amount of care burden they're going to have in the households to try and provide services when the state reduces it because of a lack of public funds. Linked to that is then the political hit. So we know that women are busy. All right, so if you are busy supplying key services, taking on the burdens, having domestic work as well as work outside the home, you have very little time to be scrolling your Twitter feed. Obviously, I know we're talking about women in vulnerable settings and they definitely are not scrolling their Twitter feed, but following the news or going to the civic meetings or groups around how you demand for better resources within a refugee camp or an informal settlement. It's the extent to which women have time to participate in civic work and political work. When that time is reduced, as it is with pandemics, as women are the focal of the response, that again has long-term consequences for women's participation. Now, we've known all this from previous pandemics, and I would say the one silver lining or glimmer of hope is because COVID-19 has actually affected women in high-income countries and rich women, people are starting to realise the gendered impacts of pandemics. And it's absolutely depressing that it's taken this, for this to happen, for people to realise, but it is an opportunity. The other thing you see is the experiences from Ebola, Zika, and HIV and AIDS means that when COVID-19 came about, women's organisations and the women's movement were mobilised to act. So you saw UNFPA, UN Women coming out and saying, right, what are the key issues? How do we work with researchers? How do we work with the movement? How do we get the Secretary General engaged? And that's been huge change. You never saw that with Ebola. You never saw that with Zika, even though Zika predominantly impacted on pregnant women, which is one of those very weird things, but perhaps we can explore that in the Q&A. So how to revisit COVID-19 going forward? What should we be doing? Firstly, we need to be supporting and advocating for gender experts at every stage of the COVID-19 response. So that's preparedness, the immediate response, and planning for any future response or recovery at every stage. It absolutely depresses me that you didn't have gender experts involved right at the really beginning who could have said, if you engage in quarantine or forms of lockdown, you are going to see a rise in domestic abuse. Any gender expert would have told policymakers this, but they were left out to an extent. So that's the first thing, gender experts. Secondly, women need to be a category on their own. It should not be women and children. So I know maybe this is the wrong group to say this, but quite often women get lumped in with children, which reinforces their care burden. It reinforces women only being seen as mothers and ignores the myriad of other issues that women face in a pandemic. Finally, I also want care to be at the centre of building back economies, recognition and value of care work as a profession that is key to planning and response and recovery to pandemics, and would also value the work that predominantly women do. And to conclude, we need to centre women as an essential part of how we respond to pandemics, not as a secondary afterthought. Thank you very much.
Thank you so much, Sophie. Ahmed, I'd invite you to share with us your reflections.
Thank you so much. My name is Ahmed Arale from Co-Group Polio and Global Health Security Project in Horn of Africa. We work in Kenya, Somalia, Ethiopia, South Sudan, Uganda, and mostly we work with cross-border communities, very highly insecure, porous borders. And today I'll give you the perspective from the field. I totally agree with Dr. Sophie on really what she has expounded on. Here in the field, really, we, as I mentioned earlier, this dire situation. There's a lot of confusion and anxiety. We are dealing with communities that were already suffering from a myriad of problems. The reason why Co-Group is working in those areas is that there were already outbreak of diseases that we had to work with the communities in these cross-border communities. You have to know that we have highly vulnerable mobile communities in Horn of Africa, especially nomadic pastoralists who make 20% of the population of Horn of Africa. There are also internally displaced people. You have countries that are facing, persistently, conflicts, political instability. So we have a situation whereby these communities, unlike people who are in urban areas, really they are out of, where they can even get health services, information on COVID. There's high literacy among these communities. So they're already in dire situation. As COVID has come, some of them really are in denial that this is really happening. Co-Group and partners also work in informal settlements, especially here in Nairobi, where we work in informal settlements. All are underserved populations in the first instance. And now we have a situation whereby their previous problems have been compounded by COVID-19. And really it is creating a lot of tension. For example, if I give you an example, currently nomadic pastoralists transit borders and they move in search of livelihoods, water, pasture. With the restrictions of this pandemic, really they are facing a very tough life. One, they have inadequate information. Getting to them was even previously hard. Getting services, health services is also a challenge. There are now communities that shun them because they believe that these mobile populations are drivers of diseases. So many people are denying them access to water and even markets. So part of these vulnerable groups, as mentioned by Dr. Sophie, we have the women, children, adolescents who are disproportionately affected by pandemics. So as people talk about how best to prepare for pandemic, we have this segment of unique special populations who really are out of the picture. whatever that comes from government or other organization doesn't get to them. On the side of Somalia, we have internally displaced people, you know, IDPs, refugees who are already in that situation, especially facing women and children. So for us in core group, what we with our partners, what we have done over the years is build trust with these communities. As you know, they live in border areas and very insecure, and many governments and organizations will not want to go to these insecure areas. As you are aware, some of them are inaccessible because of conflict. So what we have done is, over the years, build trust with them so that we are able to work with them and take services to them. So way forward here in terms of planning is to ensure that we bring the communities when it comes to preparing in the preparation for this pandemic, so that the communities can really be empowered to take up this initiative of bringing their own solutions. From the years we have worked with these communities, we were able to, you know, form community-based surveillance system, and really that has worked very well in terms of, you know, preventing and controlling other diseases. Our project was gendered, you know, right-based and gendered approach. We worked with care groups. These care groups are mothers, groups of mothers who are led by a lead mother. We have trained these mothers in all our project areas so that they can be empowered and they can take decisions and plans on their hand. The other things we have done with these communities is we have cross-border committees from these communities themselves, who on both sides are able to share information, to do you know, surveillance, to do health promotions, as well as the many community volunteers we work with, who we have embedded in these mobile communities like nomadic pastoralists. So as we look into these underserved populations, and I'm sure it will come in the Q&A sessions, we really need to understand and focus on this group. Without focusing on this group, it is going to be hard to prevent and control COVID-19 pandemic. I'll stop at that, and hope questions will come on what we have done previously and what we are able to do. Over. Thank you.
Wonderful. Thank you so much, Ahmed. So now we'd like to give all of you an opportunity to interact with each other. So we'll split you into some small breakout teams. You'll have an opportunity to connect with some other folks who are here. And again, share your insights and what you're experiencing in your communities and what was most thought-provoking about what you've just heard. So with the magic of Zoom, Damien will now whisk you away into breakouts. Again, we'll bring you back in about 5 minutes for a further discussion with Sophie and Ahmed. So we'll see you shortly. Welcome back, welcome back. I know those were very, very short conversations, but hopefully enough just to generate some interesting possibilities for a conversation here. So as folks are joining us, we have about 10 more minutes or so to, again, re-engage in a conversation with Sophie and Ahmed based on what you heard earlier, based on what you discussed in your small groups. So with that, I'd invite you all to share with us your insights and or questions for Sophie and Ahmed in the chat. So please, the bottom middle of your screen, there's an opportunity to share your questions and insights for Sophie and Ahmed. And maybe I'll just get it started by asking both of you, what has been most surprising to you in all of this? So what is really surprising?
I think I'll go first. Yeah, the most surprising thing is that, and that it has come also in our discussion, many times we talk about community empowerment, bringing communities to the table. Yet this thing really, and this was mentioned by even Sophie, that for many years she has been hearing this, and this really doesn't happen. For example, when the first cases of COVID-19 surfaced in Nairobi, really the Ministry of Health immediately contacted us so that we deploy our trusted community volunteers. These community volunteers, to the government, initially they were not given this importance. But in such a pandemic, the only people who can, go into these communities, especially informal settlements, where we have, people sharing one room, there's inadequate sanitation, water, and really the government cannot do anything. The only thing that can be done is involved in the same community. And really we have to deploy our community volunteers to do the screening, contact tracing, ensuring that they go house to house, so that they can mobilize communities to continue going to, taking children for health services, immunization, and all that. So I think this is, as co-group and partners, the communities, we believe that the communities have to be empowered. Thank you, over.
Wonderful, thank you. So Sophie, I'm gonna change the question. We have one here that came in on chat. So is there any country that got it right or has seemed to do much better in terms of having gender in all the steps of pandemic preparedness?
Thanks so much. And I'm pleased I dodged the surprising question, because nothing surprised me. If you were to write a playbook as to what would happen, everything you would imagine has happened. On the gender question from Anna, so I'm actually involved in a project with colleagues from Simon Fraser University and the London School of Economics looking at this very question. So at the moment, from a cursory view, no, we don't know yet, because obviously we have to do a systematic look at every element of the response. I know that everyone's got really excited by female political leaders, but they're just good politicians. I don't think it's because they're women. But we can unpack that if you like. I also think it's dangerous thinking that women do care work and therefore they're good in care situations. But we don't know yet, so watch this space. I will be glad to share you the results of that, and I can also put the link to the project in the chat if that's helpful, because there's a lot of interesting work that the project's doing. It has a gender matrix that is comparing lots of different countries and might be a really useful resource if that would be helpful to you as well.
Wonderful, thank you, Sophie. I would say for the group, yes, share please. So we have a question from Savannah. So at Global Health Visions, we have been doing quite a bit of research on the role of civil society in helping to both share messaging and coordinate responses to the pandemic. And we'd be interested in your thoughts, Sophie and Ahmed, about this. Ahmed.
When it comes to, messaging, and really for us, we work with, underserved communities in remote areas. And mostly here we have situations whereby literacy is an issue. We have high illiteracy. And what we have been doing is that we have been developing messages in local languages, or adopting messages that have come from risk of communication and community engagement groups, so that we translate these and then send this through our volunteers, especially those who are embedded with nomadic pastoralists and all that, because most of them are oral communities. And what we tend to do is that we give these messages to these volunteers to take them. And then many also communication materials in pictorial form, so that they can look at it, which is culturally appropriate pictorials, so that the message can be sent down. Also, we work with community radios that really are accessible. Like one of them is World Bank funded in one of those remote areas to send out the messages. So, and we do work on day-to-day basis to ensure that this information goes to these communities, because as I told you earlier, access is an issue, and you have to access them and you have to follow them. And we do a lot of outreaches to these communities, border communities, nomadic communities, IDPs, and we use a lot of the networks we created, like the care group model that we utilize, and also our network of community volunteers. Thank you. Over.
Thank you. I've just been notified we've been given the gift of a bit more time, so we have another 8 minutes here. So Sophie, any additional thoughts about this question?
Yeah, I think it's a really important one, because I think it's the innovation that happens within community responses. They always have the kind of the most effective solutions if you come with a problem. And I think what's been extremely frustrating for me as someone who's worked in this field for a while in the UK is how there's been no lessons learned from the UK's perspective from countries such as Sierra Leone or Liberia, for example, that can show you how countries can do community contact tracing, community epidemiology, that would be much more effective than, say, apps and things like that. I'm not saying that apps aren't effective, but you know, there's this huge resource. And there's this whole study on this. So, I mean, that points to the arrogance of the global north or high-income countries thinking they can't learn anything from low-income countries. But it's such an error, because if you want anything to happen, you go to the community and you find out what the response is. But it has to be meaningful. You can't create top-down engagement. And I think the gender point, I think someone from the chat has pointed a really, a really interesting question of how do you get women speaking over men when men tend to dominate the conversation? But also it points to my wider point of women's political participation. This isn't just engagement in current affairs. It's, how is a woman going to organise and mobilise other mothers to create a response to COVID-19? It's just another burden. You're just asking these women to take on more. So it's how do you engage with these communities and involve women in a way that you're just not giving them more work to do?
Wonderful. So it's all about relevancy. We have a question here from Jennifer. So do you think the fact that young people and women seem less at risk than older people and men means they are being even more discriminated against?
So I don't mind taking, so if I get Jennifer's question right, so because that means that you can ignore women even more, or there's also someone was saying to me that now it's affecting men more. People are quite interested in these kind of gendered aspects of men's health-seeking behaviour, and women are therefore sidelined a bit. I think there's a line of argument that does say that, but I'd also caution we're sort of not even at the end of this, we're still at the beginning of this, and you're actually seeing rising numbers of young people actually now getting infected. So even though we know it targets older and more vulnerable populations, you actually do see young people, so it's too soon to tell. But yeah, I think there's something really interesting there in that actually then men are starting to dominate these conversations around gender that we've been having for years in HIV and other aspects of health. So yeah, it's a really great question, and I think it's a kind of, I don't want to answer all these questions with watch this space, but I think it's something that should be followed carefully.
Thank you, Sophie. So I have a question now for Ahmed. So the nomadic pastoral societies resonate with me. Could you please share how you have involved women from these groups, knowing that men usually lead the group and make decisions? Are they being tested for COVID?
Yeah, thank you so much. I really agree that when it comes to nomads, they are conservative, and really women have their roles, and it is men who are decision makers. This is something that over the years we have tried to, work on, so that women's voices in these nomadic communities are really hard. And nomadic women do a lot of work, and in such a pandemic, it will definitely disproportionately impact on them because they are the people who give the care and all that. So what we have been doing is working with community elders and religious leaders, so that the nomadic communities have the voice. When it comes to testing, really for this pandemic, it has been hard. We tried to do outreaches, especially border areas where the nomadic communities cross, in formal areas with their herds, in the watering points, markets. But with the pandemic, really, many people are even shunning the nomadic communities and telling them, please don't come to these watering places because we are afraid of COVID-19. So what I can say is that testing for COVID-19 among nomadic communities minimal. So we are trying to integrate COVID-19 testing in our outreaches that targets nomadic community, but really it was tough, especially with the movement restrictions and all that. And for them also, because of their perception that this is happening in towns, they also go further interior. They will not want to come near settlements also, believing that all diseases originate from them. But we have also seen the other way around, that communities want to go to out of town, to go and live with their relatives in the bush, with the nomads. They believe that the virus is going to be less there because of no much contact with the people. Yeah.
Thank you, Ahmed. So we have just about 2 minutes left. I'll maybe ask one final question to each of you. So coming out of this crisis, and you touched on some of this, Sophie, there's the opportunity to learn and apply going forward. So if there were one thing that you each think that we absolutely must take advantage of in terms of an opportunity for dealing with a situation like this differently in the future, what would it be? So let's go with Sophie and then Ahmed.
Value care.
Value care.
That's it.
Okay, good, simple, straight and to the point. Ahmed.
Community empowerment and bringing communities to the table and getting community-driven interventions. That is what we think is going to be valuable. Instead of thinking about communities when there's a large scale or a pandemic like this, we need to be thinking community always, so that we stop spread of diseases at the source.
Wonderful, thank you. So value care and community-led are our two big takeaways. All right, so some instructions about what's happening next. You'll return to the live screen, and Damien is going to share a link with you here. So you'll be back to the live stream. I understand that our yoga instructor, unfortunately, who was meant to be with us, was not there as of the last check. So instead, we'll hear headlines from each of the breakout groups. So you'll hear an opportunity to get sort of, the briefest glimpse of what some of these other conversations were. So thank you again to both of our speakers, to Sophie and Ahmed. Thank you all of us for joining, or all of you for joining us in this conversation, and enjoy the rest of your day. Take care.